Now, let us begin with the vertical dimension or the vertical jaw relation. The vertical jaw relation is described as the distance between two selected anatomic or mark points. We usually see in our clinics that we mark the tip of the nose and the other on the chin. One point is fixed and the other is movable. So, in this situation, you'll all be able to guess that the point on the tip of the nose is the one that is fixed, and the one on the tip of the chin is the one that is movable. While recording your vertical dimension, there are two distinct dimensions that need to be recorded. The first is the occlusal vertical dimension, also known as the vertical dimension of occlusion, and the rest vertical dimension, which is commonly called the vertical dimension of rest. So, according to GPT-8, the relations that are established by the amount of separation of the jaws in a vertical direction under specific condition is known as the vertical jaw relation record. So, what does this vertical jaw relation or the vertical dimension emphasize or relate? It provides an optimal separation between the maxilla and the mandible. The vertical separation depends on the temporomandibular joint and the tone of the muscles of mastication. And what would happen if this is dependent on the TMJ and the muscles of mastication? An incorrect measurement, which means an increase or the decrease, is going to directly affect the temporomandibular joint or the muscles of mastication, which would be strained and thereby leading to changes later. So, the factors that affect the vertical jaw relation are basically categorized as the ones that depend on the teeth and the ones that depend on the musculature. The ones that depend on the teeth, they act as vertical stops and it establishes a relationship. The opening and closing muscles tend to be in a state of minimal tonic contraction, which influence the role of the musculature in establishing the vertical jaw relation. So, what would happen if there is an alteration in the vertical dimension? In the first situation that we'll be discussing is when the vertical dimension is increased. When the vertical dimension is increased, it leads to increased trauma to the denture bearing area, which means that there is excessive force or pressure that the patient needs to exert in order to occlude the lower and the upper jaws, leading to increased trauma to the force directed area, which is the denture bearing area. It gradually results in the onset of joint pain and muscle pain. This increases the lower facial height. As the vertical dimension is going to be increased, the lower facial height would appear to be larger, somewhat looking like the most famous character Frankenstein. That will also lead to cheek biting and something that is going to be really bothering the patient as it is going to compromise the function of the patient, which is difficulty in swallowing and speech. This is also going to lead to pain and clicking in the temporomandibular joint, stretching of the facial muscles and fatigue, tension in functional speech, pathological bone resorption, and abnormal wearing of the teeth. So, what happens when this said vertical dimension is decreased? It again, if increase in vertical dimension is going to increase the lower facial height, a decrease in the vertical dimension is going to decrease the lower facial height, which in the correct vertical dimension is equal to the upper facial height. It is also going to lead to pain, discomfort, and clicking in the temporomandibular joint. It is going to lead to loss of lip fullness and loss of muscle tonicity. The vertical dimension record can be recorded in two parts. One is the vertical dimension at rest position, and the other is the vertical dimension at occlusion. So, in normal patients, such as all of you, the teeth are not in contact at rest, which means while listening, for example, actually, while listening to this said lecture, you're either in awe or in shock or are dying of boredom. In all these situations, your teeth are at rest, which means they are not in contact. unless you're munching on something, which means that in occlusion, your teeth are in contact. This separation between your teeth not being in contact at rest and the teeth being in contact at occlusion is known as the freeway space. And this relation should be maintained in complete dentures. So, what are the factors that influence the physiological rest position? It is influenced by the position of the mandible, which is influenced by gravity and the posture of the head. Recording a physiological rest position, all the muscles affecting this record should be relaxed. And also, a very important factor is assessing and determining any underlying condition, which may be the presence of any neuromuscular disease in the patient, which again influences the rest position. So, the physiological rest position of the mandible is not determined by teeth, it is established by muscles and gravity. The vertical dimension of occlusion is established by the natural teeth when they are present and are in occlusion. So, what are the factors that influence this said rest position? It is influenced by the posture of the head. I want all of you to try it. Whether you're lying down, sitting up straight, or bending down, the posture of your head or posture of you is going to be determining the rest position, whether the patient is relaxed or conscious. While recording your vertical dimension at rest, all of your teachers might have said that the record needs to be made very fast. If you delay it, the patient tends to change the rest position. Any presence of any neuromuscular disturbance, the duration of the time that the patient is asked to relax, and the different techniques that are used. So, what are the methods of recording the vertical jaw relation? They are physiological and mechanical methods that we often use. So, the most commonly used method is the ridge relation. Again, this theoretically is the ideal method to be used. However, practically may not always be possible. This is done by determining the distance of the incisive papilla to the mandibular central incisor, and this should be roughly 4 millimeters. The distance of the hamular notch to the retromolar pad and the parallelism of the ridges. While all of you had set your done your teeth arrangement on your ideal cast, you can go back and look and determine whether these relations are maintained or not. You can measure from the former dentures. You all, the students who have given complete dentures before or have seen their seniors fabricate complete dentures, you would know that it is extremely difficult to satisfy a patient who is a previous denture wearer. This is because the patient is well adjusted and acquainted to the denture they are wearing. So these dentures can actually be used to your advantage by making measurements from these dentures. The next are the pre-extraction records, where you can get profile radiographs such as OPGs, profile photographs, profile silhouettes, profile tracings on lateral cephs, and previously articulated cast, if they can be found. You can do facial measurements. You know that an increase or decrease in BD greatly affects the lower facial height, which should be established. So facial measurements using dacometers, Billy's gauge, etc. help you establish the correct vertical dimension. And the most commonly used method in our practice, the Niswonger's method. Now, coming to the last, the horizontal jaw relation. The horizontal jaw relation, also known as the centric relation record, is a maxillomandibular relationship independent of tooth contact in which the condyles articulate in the anterior superior position against the posterior slopes of the articular eminence. In this position, the mandible is restricted to a purely rotatory movement. From this unstrained physiologic maxillomandibular relationship, the patient can make vertical, lateral, or protrusive movements. It is a clinically useful, repeatable reference point, as described by GPT-9. The centric relation and the centric occlusion are interrelated, which means the occlusion of the opposing teeth when the mandible is in centric relation is what is known as the centric occlusion. Now, the third point or the third term that greatly confuses students is the complete intercuspation of the opposing teeth independent of condylar position, which is sometimes referred to as the best fit of the teeth regardless of the condylar position, also known as the maximal intercuspation position. So there here I have a short video. Here in this they first established the centric relation record wherein the condyle is articulating in a particular position which is repeatable and reproducible by the patient wherein the muscles are strained. So it is defined as the anterior superior position of the condylar disc assembly. So they have established that particular assembly. Now you will see that once this particular relation is established, the teeth are added to this particular relation. The teeth, when added, may not come in total contact, which means that in centric relation record, the teeth are not coming in their best fit position. This record is the centric occlusion, which may or may not coincide with the best fit position or the maximum intercuspation. So, to conclude or to concise and tell you the relation of this video is that the centric relation record depends on the condylar head and its relation in the glenoid fossa. The centric occlusion is the occlusion that is established at centric relation, and the maximum intercuspation is only solely dependent on the teeth, which is in the best fit point. So the centric relation in occlusion is the centric occlusion, which may or may not coincide with the maximum intercuspation position. So the significance of centric relation are innumerable. The centric relation and maximum intercuspation should coincide while fabricating a complete denture. Thereby, if the horizontal record is made accurately, the centric relation will be equal, the centric relation and the centric occlusion that will be attained at this particular relation will be equal to the maximum intercuspal position. The centric relation should be in coordinates with the transverse horizontal axis and the vertical relation. It should be reproducible, comfortable to the patient. There should be easy excursion and it should be conducive to the patient's health. Now, techniques to record the centric relation it can be classified as active methods or passive methods. The active methods are swallowing, touching the most posterior part of the palate with one's tongue, and the passive methods can be Dawson's bimanual manipulation, chin point guidance, or Rothbard technique. The most common methods that all of us use in our school colleges is we ask the patient to touch the posterior most position of the palate with their tongue and close, or swallow and close. So to conclude, we have gone through the various type of jaw relations, starting with orientation, vertical, and then followed by horizontal. We understand how it is important for us to establish the accurate record in order to be able to reproduce and form a complete denture prosthesis which will be aesthetically pleasing and functionally viable to the patient. Thank you for your attention. Hope to see you all soon in another session.